All right, everyone, it's the top of the hour. We'll get started. I'd like to welcome you to today's GlomCon. Today is our roundtable discussion with the ERA, and our topic is investigating COVID-19 and kidney disease using electronic health records. I am going to turn it over to Dr. Kate Stevens, who helps us plan and execute this series. She's a consultant nephrologist at Queen Elizabeth University Hospital in Glasgow.
Thanks, Dia. So it's a real pleasure to welcome our two speakers today, both from the London School of Hygiene and Tropical Medicine. Dr. Laurie Tomlinson, Associate Professor, Epidemiologist, Nephrologist, and part of the team behind the Open Safely platform. And her colleague, Viyaasan Mahalingasivam, Doctoral Researcher and Consultant Nephrologist. So both talks today will run back to back. Discussions and questions will take place at the end with our panellists today, my friend and colleague, Dr. Paddy Mark, Professor of Renal Medicine at the University of Glasgow. So we're UK heavy today, and I'll just hand over to you, Laurie, to get us started.
Great, thanks, Kate. So I'm just going to start my slides. So thanks everyone for giving up some of your Sunday to hear this. I hope it's of interest. It's quite epidemiological, which is obviously fascinating to me and V, so hopefully you'll find it similarly. So I'm going to talk about some of my experience with Open Safely, just to say I don't have any conflicts of interest regarding this work. So before COVID, I was a member of the Electronic Health Records Research Group at the London School of Hygiene and Tropical Medicine. And that's a centre of public health research based in London, collaborating with lots of different groups around the world in different aspects of epidemiology. And our main focus in our group was about using big data resources to do different types of research. And my particular focus was on particularly in association to RAS blockade. So at the beginning of the pandemic, before I talk about that, because this is very global, and I can see collaborators from around the world, I just wanted to tell you a little bit more about UK primary care data, because we are incredibly lucky to have this resource and it's not the same everywhere. So in the UK, we have access to pseudonymised electronic healthcare records from patients interacting with their primary care providers, their GPs. And one of the most common sources of this that you may have seen in multiple research papers is CPRD, the Clinical Practice Research Data Link. And this provides a wealth of pseudonymized information. So it's got the diagnoses of a particular patient, for example, if they've had previous cardiovascular disease or diabetes, in a particular coded form. It contains all of their prescriptions that can be developed into a continuous prescribing course for conducting drug studies. It contains information about whether they're referred to hospitals, and also the results of blood tests that the GP orders, including things like kidney function and full blood count. So a huge wealth of resources. And CPRD has historic and current information on about 10 million patients. However, when COVID-19 came along, we were really lucky to be able to think about whether we could develop even larger resources. And we were in our research group desperately thinking, what could we do to help the course of the pandemic very early on? And so we were very lucky to work with collaborators who are able to pull a lot of strings. So my boss at the London School, Liam Smith, spoke to Ben Goldacre, who's based at the EBM Data Lab in Oxford. And together they pulled together a plan to pull an even larger group of primary care records and link them to other data sources, specifically to conduct research into COVID-19. And that's what developed into the Open Safely platform, which I've been lucky enough to work on for the last 18 months. So this contains a number of different linked data sources. The original source of primary care data was from TPP, which is one of the two main UK providers of resources for GP data. And they, as you can see there, they cover about 24 million people. And that was linked to information about COVID tests, to information about hospital admission, including ITU and renal replacement therapy, for example, to death certificate data from the Office for National Statistics, and then other specific data sources, such as one of the intensive care audits in the UK called ICNARC, And this formed a huge source of data, over 10 terabytes, or to put it in easily identifiable forms, an Excel spreadsheet that's 6 rows wide and 60 billion rows long. Now, this data is accessible within a trusted research environment, and this is different to previous access to UK primary care data. And so I'm just going to explain a little bit about how we are lucky enough to have access to this information and the extremely strong security network that surrounds it. So at the heart of it is the data held by TPP, the GP care provider, in their extremely secure platform. And really nobody else outside TPP is able to access that data. So it's as secure as when a GP uses it for clinical care. But what they worked out, what they planned to do very early on in the pandemic, was a way to take sections of that data outside of the initial, the care providing network into a similarly secure server in aggregate form and link it to other sources of data, such as the COVID testing, which I mentioned earlier. And only the TPP team and then the kind of software engineers based in Oxford are able to access level 2. And as researchers, we begin access in level 3, where we develop code to run against the level 2 data, and I'll talk you through that in a minute. But essentially, we draw out aggregate data, or the results of analyses conducted against the level 2 data, and we're able to access that in level 3. And at this level, there is extremely minimal information that could ever be linked back to a patient. And in fact, we go on to carefully assess that to see whether there is anything, such as through release of small patient numbers, that may lead to identification of an individual patient, and make sure that that never goes into the public domain. So this type of research environment is much more secure than the traditional ways of accessing patient identifiable information, or not, well, pseudonymized information that I mentioned earlier on. And very briefly, this is how we work with the platform. The first stage is to develop a collaborative protocol with kind of content experts, analysts and epidemiologists in that area. And that's fully developed and then time-stamped before we begin research. We then link that to coded information to identify specific groups of patients that we're interested in. And that's typically done between a clinician and an epidemiologist to ensure that we've got fully captured that patient group that we're interested in. And that information, in fact, is all in the public domain. So we've developed a platform called Open Code List, where all of the code lists that we use for open safety research are accessible for reuse by any researcher. You can Google it and you'll see this Open Code List website. You type in your interest, like renal replacement therapy, and then you can download the codes that we are working with. And you can see the full process that led to the development of that coded information, including all of the discussions on GitHub, the open source coding platform. So this is some of the GitHub discussion that you could click through to if you wanted to read more about the development of renal replacement therapy. And you can see that this was kind of taking place very rapidly at the beginning of the pandemic, where we were using our clinical information and epidemiological and primary care expertise to try and develop what we thought was the most accurate way of categorizing patients. So once we've developed the code list we need, we apply that process to all of the data and write this into a program, which can then be run against dummy data, which looks like real GP data, but is all essentially made up, just to ensure that the entire program works. And then we conduct the analysis, running our program against the level 2 data and bringing the results out into the level 3 for it to be reviewed. And then eventually all of our code and results are also available for public review and reuse. So the Open Safety platform is continuing to develop. You can read all about it on this website. The publicly available code, as I've just mentioned, is all accessible on GitHub for every single analysis that's been run. And the code lists are also available, as I mentioned. So that was a huge amount of work by epidemiologists, clinicians, software developers, and the primary care providers. And it led to us being able to write this paper 42 days after we set up the platform, which looked at the factors associated with severe outcomes after COVID-19 in the electronic health records of 17 million patients. This was one of the main outputs of the research, and you can see here, or you can imagine here, that there are, we're looking at the particular risk factors and demographic features associated with each patient, and looking at the associations between this across the population, taking into account other parameters of interest. If you think back to the beginning of the pandemic, it was evident that elderly patients very early on were doing much worse, but we were able to kind of look in great detail at the very strong and steeply associated relationship with age, as well as taking into account many other comorbidities that could have led to severe outcomes. So, for example, it was clear clinically that we were admitting a lot of patients from ethnic minority groups, but there was a lot of discussion about whether that appeared to be the case simply because they had a higher prevalence of diabetes and other health problems. But we were able to take that into account and show that this relationship with being from an ethnic minority group in the UK and the severe outcomes from COVID was independent of other factors that may have determined it, such as diabetes. This is just very simple descriptive work to try and get a handle on the very unclear clinical picture that was taking place in the middle of the pandemic. We were able to drill down more into kidney-specific aspects in relation to COVID outcomes. So here we were able to look at baseline kidney function and show this strongly increased risk in patients who had GFRs less than 30. And that was even after taking into account the people who had an organ transplant, again, who had a very increased risk of severe outcomes, and also patients who were on renal replacement therapy. And this was consistent with evidence generated from many different groups around the world showing the severe impact of COVID-19 in patients who were undergoing dialysis. This is a very social media savvy group of people. And so I just wanted to say a word about our statistical approach, because it's something that's been heavily criticised, and particularly in the last week, which some of you may have seen. At the time that we undertook this paper, there was no community testing for SARS-CoV-2 in the UK. So it was impossible to understand how many people in the community were infected. The only outcome we were able to look at was COVID-19 deaths. And we sought to conduct descriptive research across the population, very much aware, we were clinicians undertaking this work, that some people were shielding and therefore would be at lower risk of infection and lower risk of severe outcomes. So we were very much able to interpret our work through the lens of the groups of people that had already been asked to isolate. But we were keen to try and understand other groups of patients who were at high risk of death from COVID-19. So regardless of the potential limitations of our work, which we think we were open about, it did have a very major impact. It was a very useful resource for kidney advocacy groups around the world who wanted to have clear data to highlight the risks to patients with kidney disease. So this was one that highlighting our work by the ERA. In the UK, it was used to form an individual risk assessment tool for severe outcomes from COVID-19. And this was used to assess particularly high risk groups among NHS staff. This is way back when infection rates were very high and obviously there's no vaccine or even very decent treatments at that stage. It also went on to help identify some groups that had been missed from the initial groups of patients who were identified to be vulnerable for COVID-19 and were available to have extra resources. So in particular, the CKD5 group, who went on to be classified as clinically extremely vulnerable in the UK, but had been omitted from early protection, so to speak. And it also informed the UK vaccination strategy, where patients who were originally classified as high risk, such as organ transplants, dialysis patients, were prioritised for vaccination, but also patients with CKD. all fell into the early priority groups. And we've gone on to do lots of other research into other outcomes for COVID-19 and other aspects of kidney disease, which Vi is going to pick up on shortly. As well as specific research around kidney disease, we've conducted a whole range of research projects looking at different topics. And in particular, one of the pieces of work that we're most proud of is this work that was originally asked for by the UK government, looking into the risks among patients with learning difficulties, which led to them being identified as a high-risk group for clinically extremely vulnerable and also prioritised for vaccination. So as you'll see on the programme, Vi is going to talk about his research shortly through an NIHR doctoral fellowship, we're very pleased to have him join the group, a second renal head for me to talk to. And also there's a large programme of ongoing research through the national core studies, which I'm particularly involved in, looking at long-term outcomes of kidney disease in various different ways, but again, focusing to some extent on kidney disease and kidney disease patients. As well as those original linkages, which I've mentioned, we've grown many other pieces of linked data along the way. These are some of the new linkages that are just getting implemented at the moment. So 2 of our large UK hospitalised patient cohorts, which provides very detailed information about the severity of disease, the levels of different organ involvement and so on. And we will be able to help the researchers there with long-term follow-up through their primary care record and other linkages. And we're also linking to the COVID-19 infection survey, which is a fantastic UK resource where patients are identified randomly from the population and tested for COVID-19. So all observational data, like the primary care data that I've talked about so far, is heavily limited by the fact that who is identified is influenced by who is able or willing to go and get a test, whereas the COVID-19 infection survey provides evidence from a randomly sampled portion of the population. So looking at things in a different but complementary way. So just to conclude, it's been an absolute privilege to be involved in this research over the last 18 months. We've collaborated with a really wide range of people, trying desperately to try and play our part in dealing with the pandemic. And as you've seen, we've had incredibly fortunate access to data, which has all been enabled by COVID-19, but we're very much aware that this is individual patients' research data that we are fortunate enough to be able to use. In the UK, there's been a very broad concern about access to health data, and that's influencing the public mood and patients' concerns about whether they will allow ongoing access to data. And that's something the government is looking at very actively at the moment. And it's likely that there will be very substantial changes in the way that academics are able to access healthcare data. But one of the possibilities is that it moves towards a trusted research environment model, like the one I've described today, where there is essentially no data being sent out to different computers, even in very secure settings. The scope of the work we've been able to do, seen with a nephrological hat on, provides huge opportunities to better understand kidney disease. If we were able to link up our different kidney resources, such as the renal registry, sources of renal biopsy information, much more detailed information about blood testing in hospital, like immunology data, we would have a huge opportunity to be better able to understand the drivers of kidney disease. And so that's something I hope will happen and develop over the next few years. I just want to thank my amazing research groups and the EBM Data Lab at Oxford, who I've been very fortunate to work with, and obviously thinking of all the patients who have provided the data. So I think I'm handing on to Vi now. I'll stop sharing.
Okay, thanks, Laurie. So Hello, everyone. My name is Viyaasan Mahalingasivam. I'm a nephrologist based in London. And as Laurie mentioned, I've recently joined the Open Safely team to start a doctoral research fellowship looking into COVID-19 and kidney disease. And I'll be talking to you today about some of the epidemiological aspects of doing this research using electronic health records. So yeah, I haven't got any conflicts of interest to declare. So as I'm sure many of you will remember, since very early on in the pandemic, there were multiple reports about the association between COVID-19 and kidney disease, and as well as the risks for patients from COVID in people who had pre-existing kidney disease. And now that we're over a year and a half in, we have the opportunity to sort of move beyond those early reports and our early sort of clinical impressions and undertake more comprehensive epidemiological studies to be able to better understand what's going on and what may lie ahead for our current and future patients. So in this talk, I'll be focusing on two main broad questions relating to two groups of people with some overlap. The first question is how people without pre-existing kidney disease develop kidney complications such as end-stage renal disease after COVID-19. And the second question is how people with pre-existing kidney disease develop predominantly non-kidney complications after COVID-19. I'm not going to mention vaccination in this talk. However, some of the epidemiological aspects we'll be discussing may be also applicable when thinking about a whole range of studies, and that might include the effectiveness and complications of vaccination as well. So let's break down the first question, and here are some of the important and interesting issues that we need to address in relation to this broader question about kidney complications in people with and without pre-existing kidney disease. And those include whether long-term adverse kidney outcomes such as disease or reduction in renal function or CKD or AKI. We want to know if this is different to comparable hospitalized infections such as pneumonia. And what about asymptomatic or non-hospitalized SARS-CoV-2 infection? Does this lead to longer-term kidney outcomes? So let's think about the population we're interested in to answer these questions. So these diagrams are not to any kind of scale, they're just to illustrate some concepts. So here we have the general population, including some people with CKD, and some of these are on dialysis or with a kidney transplant. As we're interested in people without pre-existing kidney replacement therapy, we want to exclude those on dialysis or with a transplant. But we do want to keep in people with CKD, as it will be important to know whether they too are at risk of these kidney outcomes. However, for some outcomes, we will need to restrict to people who we have a baseline EGFR. And so that means that our general population isn't quite so general. And bear in mind, there will be people with CKD who may not know that they have we may not know have CKD because they haven't been tested, and so they may also fall outside of this circle. We may wish to restrict further to people who are hospitalized with COVID if we're interested in that particular subset. But this doesn't necessarily need to just be people with a baseline EGFR if we're looking at hard outcomes such as kidney replacement therapy. And what about our comparator groups? So the first thing to consider is whether we should use contemporary or historical groups to compare to. And for obvious reasons, historical groups aren't ideal, but they do help deal with this big problem of misclassification when it comes to people who are not coded for COVID. So if we do a contemporary comparison with the general population, we're inevitably going to misclassify people who are infected with SARS-CoV-2 and potentially resulting in underestimation of the effect. On the other hand, using a contemporary comparison does have its benefits, as it allows us to finely adjust for changes over time. And that's especially important considering that the onset of the pandemic was in many ways an epochal moment with wide sort of environmental, economic and political ramifications. The other aspect to consider is whether we restrict to and compare hospitalised populations. So this will allow us to be able to quantify the extent to which kidney outcomes are caused by COVID, rather than as a consequence of just being in hospital or being in hospital for a pneumonia. However, comparing to a general population comparator group will allow us to be able to quantify the overall rates of outcomes and gauge the burden of these outcomes as a result of COVID. So I've just got here an example of a historical comparison of people discharged from hospital after COVID compared to some historical groups. So one is a general population comparator, and the other is people who were discharged after a pneumonia. And as you can see, after adjusting for age and sex, people hospitalised with COVID were at much greater risk of these outcomes compared to the general population. But compared to the people who were discharged after hospitalisation for pneumonia, there was little difference. And that may be because the populations are not quite the same. So in this case, the historical pneumonia group was much older than the COVID group. And so there may be differences in susceptibility to hospitalisation, or on the other hand, if those people who were most sick from COVID were less likely to survive to discharge, there might be a survivor bias in that the people who do survive to discharge are fitter or healthier than those people who survive to discharge from a pneumonia. So it's not always straightforward to make the direct comparison. And that's something to always bear in mind with these historical comparisons. So now let's look at our second set of people. And this is looking at people with pre-existing kidney disease and whether they are at risk of complications because of COVID. As Laurie mentioned earlier, it has been shown that people with CKD are at increased risk of death after COVID. But what about longer term outcomes such as later death, kidney outcomes, cardiovascular outcomes, hospitalisation and so on? And what about our transplant patients and outcomes related to transplantation such as graft loss or rejection? So again, we need to get the right population. So here's everyone again. And now here are people with CKD, including those who are on dialysis or on transplant. But in reality, we won't have everyone with CKD because not everyone with CKD will have been identified as having CKD. And in addition, we may end up misclassifying some people who don't have CKD as having CKD, and we'll come on to that shortly. And so this is our sort of final CKD study population, which we hope will be as close as possible to the true CKD population. But how do we ascertain CKD accurately? Unfortunately, primary care CKD registries are often incomplete, and whilst they're specific, they're not very sensitive. And so many people with CKD won't be coded as such. So we need to try and determine who has CKD based on laboratory results ourselves. And this usually involves identifying people who've got an EGFR of less than 60. The important thing to bear in mind when it comes to thinking about EGFR measurement is the idea of the informed presence bias. And that is that people who are more sick are potentially more likely to experience a particular outcome. But they're also more likely to have kidney function testing beforehand. Furthermore, there may be health inequities, which mean that socioeconomically disadvantaged groups often have less access to healthcare and therefore fewer tests as well. And these factors can have an impact on generalizability. So there are different definitions that we can use to determine who has CKD. One that's commonly used is the single most recent EGFR, and that might involve excluding any EGFR measurements around the time of hospitalization or hospitalization for a coded AKI, as that eGFR may represent an AKI rather than the true baseline GFR. However, excluding those measurements might reduce our sample size, and the same goes for the KDIGO definition. So although this is the guideline clinical definition, it requires 2 eGFR measurements separated by 90 days, and that would mean excluding people without those 2 measurements. There has been some work done in the UK and in Sweden, which found that the prevalence of CKD using a single most recent eGFR was better closely aligned to what prevalence studies have shown. We could look at mean GFR over a 1-year period, or we could look at peak eGFR. Sometimes imputational methods are used, again, using peak eGFR after an AKI episode, or using an arbitrary eGFR of 75. eGFR slopes can also be used and may be useful when looking at differences between scheduled and unscheduled testing within study populations. And lastly, when calculating eGFR from serum creatinine, it's better to do this at the study rather than using a reported eGFR, as the same equation can be used consistently. So here are some examples to illustrate the problems we might face. And here, just imagine that we're looking from just before the start of the pandemic, so beginning of 2020. So this particular patient has blood tests 1 to 2 times per year and has a big drop off in eGFR into the 40s in 2019. So with the exception of the KDIGO definition, all of these definitions would classify this as CKD, even though, if I saw this, I would think this could well be an AKI. And if this person was hospitalized shortly after the measurement in 2019, if we were dependent on an explicit AKI code and there wasn't one, then the AKI here would still be misclassified as a CKD. But what if this was the reality for the patient, and that blip in mid-2019 was an AKI, and then the patient recovered back towards baseline? This would mean that several of those definitions would have misclassified the AKI as CKD. And note that the mean GFR, eGFR over 1 year would still continue to misclassify CKD, even though he's clearly returned back to baseline with an eGFR well above 60. In this next scenario, this person appears to have a progressive decline in kidney function, fairly linear decline, although only 3 measurements. And all of these measurements would ascertain CKD except for the KDIGO definition, as there was only 1 measurement less than 60. But if that reading, again, was just before a hospital admission, it might have been excluded if we applied the hospitalization exclusion criteria, while if an additional test was done a few months later, this would have confirmed progressive CKD and confirmed the correct diagnosis. So it all really depends on when the tests are done and for what reason. So we've looked at how we may be able to figure out who has CKD as best we can. Now let's think about dialysis and transplant. So kidney replacement therapy is a hard endpoint, but because it's relatively rare, it requires a large sample size and long follow-up in order to have adequate statistical power. Ideally, we'd like to use representative kidney replacement registries, which can be linked to integrated primary and secondary care data sources. However, often patients are only recorded as being long-term dialysis patients if they've survived for 3 months. So many of these patients might end up being misclassified. Registry data isn't always available for linkage. So the other thing that we can do is look at primary care coding or surrogate coding in order to identify our dialysis population. And here's an example from an open safely code list of some of the codes for peritoneal dialysis as an example. So we've looked at our populations. Now let's think about COVID-19 itself and how we go about determining who has had COVID or SARS-CoV-2. So here we rely on access to testing data or COVID. The big problem, certainly in the UK, was that COVID was not always properly ascertained using testing. So especially in the earlier stages of the pandemic, there was a lack of testing infrastructure as well as a lack of or a reduction in access to healthcare. Coding may also have been incomplete around this time, and so these may result in biasing our ascertainment of people who had, in particular, non-hospitalized COVID. And that's why historical comparators may be useful to help make our effect estimates, which are then not diluted by people who are misclassified as not having had COVID. And finally, let's look at outcomes. So what about our kidney outcomes in people without pre-existing kidney disease? In terms of AKI, so that's dependent on the quality of coding and tends to be better in hospital than primary care. In the UK, there's been incentivization for coding of AKI in hospitals. So, we think that that's something that's improved considerably. End-stage renal disease is a relatively concrete outcome. It is usually dependent on the quality of coding. Looking at EGFR of less than 15 in primary care blood tests may not be as reliable as patients with advanced kidney disease are more likely to have tests done in secondary care. Similarly, people with end-stage renal disease who are for conservative management may not meet the definitions that are listed when we use our codes for kidney replacement therapy. And on the other hand, people receiving acute kidney replacement therapy may be misclassified as end-stage renal disease, although this is likely non-differential. When thinking about percentage reduction in EGFR or new CKD, this depends on what the baseline EGFR is, as we discussed earlier on. It's also possible that there will be misclassification of AKI. So sometimes a reduction in EGFR is actually AKI rather than being a new permanent reduction in kidney function. There may be differentially reduced ascertainment due to the pandemic because of reduction in routine healthcare, whilst the informed presence bias also potentially holds true again if people who are more sick are more likely to be tested and therefore reaching the percentage reduction endpoint sooner. And that might lead to an overestimation of the effect. Relying on the KDIGO definition, so having multiple measurements spaced 3 months apart, may also result in a survivor bias where sicker people may be more likely to die and they've got that competing risk of death and die before they reach their second test result, leading to an underestimation of the effect. And lastly, proteinuria is a difficult outcome to utilize as it's unlikely to be systematically ascertained unless there is a particular indication such as diabetes. So this is a study that was published using Veterans Association claims data from the US, comparing people with COVID-19 to a contemporaneous group without. And as you can see, there was an increase in all the measured kidney outcomes, and they've also reported the absolute risks as well as the relative hazards, which show that even though the hazards of complications such as AKI and EGFR decline were less than they were for end-stage renal disease, the absolute risks were much higher, and that might inform how we plan future service configurations. However, it's important to bear in mind that this may have been affected by the informed presence bias, affecting those outcomes such as percentage reduction in GFR. And just to illustrate that, this was another piece of work that was done using Open Safely, which showed how recorded AKI in hospital and hospital coding and death certificates went down during the pandemic, sort of highlighting the fact that sort of routine documentation was not quite the same as it was beforehand. And lastly, what about complications in people with pre-existing kidney disease? So the outcomes we were able to investigate really depend on the availability and reliability of coding. And coding practices may be affected by financial incentivization. So those diseases which require accurate coding are sometimes incentivized in that way and may be easier to detect. It's also possible to look at surrogates for diagnoses through prescriptions. So things like inhalers or anticoagulants may help us identify new respiratory disease or thromboembolic complications. So some final thoughts. So access to high quality linked data will allow us to answer important epidemiological questions about the long-term impacts of COVID, but there are important methodological challenges that need to be worked through. COVID-19 has introduced additional challenges and the impact of the pandemic on wider healthcare even more so. And I hope this presentation has just highlighted the importance of using robust statistical methods and lots of sensitivity analyses to ensure that we assess the definitions that we use and the extent to which outcome-dependent testing for EGFR is at play. And thinking about our broader research infrastructure and building it up within electronic health records, we need to have improved access to linkages, so including things like secondary care blood results, secondary care drug data, end-stage renal disease registries, and clinical trials. We need to develop registries to be able to monitor for rare secondary care outcomes like immune-mediated kidney diseases. And as Laurie alluded to in her talk, sharing of analytic code can improve transparency and encourage a culture of external review and replication of our methods. So many thanks to my colleagues from near and far who've helped me think through these issues over the past 6 months. Thank you.
So thank you very much, Laurie and Vee. So they were both fantastic presentations, and you made what I always think as quite a difficult topic very accessible. It's very easy to follow and understand, although I think that's testament to your talent rather than the fact that this is straightforward, because it's clearly extremely complex. So I'm going to unusually just pass over to Paddy, who's going to ask the first question.
Okay, so thank you very much. So I'm Paddy Mark, so I'm a nephrologist in Glasgow, and I'm going to start with a very, very short anecdote. But I went, during my talk, I went back to my old emails, and Laurie and I were involved in an email conversation on the 14th of March, the afternoon after of 2020, obviously the afternoon after I'd just seen my first patient with COVID. And Laurie and I were asked to comment on the rates of AKI and mortality with inhibitors of the renin-angiotensin system. And I, in my usual way, said, I'm too busy to deal with this. I'm just worried I'm going to die and all my patients are going to die. But Laurie, being slightly more thoughtful, was able to provide not just a sensible answer, but obviously that sort of led to lots of this work. And I'm going to bring that on to Maria Soler's question, which has been a lot of discussion about RAS blockade and COVID-19 infection severity. What's your definitive thought on that, Laurie? Is there a link between RAS inhibitors and acquisition of COVID and severity of outcomes, or is it all just confounded? Oh.
So Maria Jose knows as much about this as anybody in the world, I think. But I think one of the other remarkable things that's happened during COVID is not just the observational opportunities that we've discussed today, but the enormous acceleration of clinical trials. And in the time that it's taken many groups to conduct observational studies, other people have set up and initiated and to some extent completed randomized trials into the effect of RAS blockade. And those don't seem to show any strong effects in either direction. And so that's in terms of the treatment of COVID-19. Obviously, there's a separate question about whether use of the drugs prior to infection with COVID-19 alters outcomes, and that's something that's really only available in observational data. And my working with studies around RAS blockade for years has shown me that it's an extremely difficult area to get what we believe to be a true answer on. But I don't think there's any strong evidence that they either protect from or provide susceptibility to infection with COVID-19.
Thank you very much.
I'm keen to hear.
That was a really good answer. No, I mean, we could probably go to Maria, but just in the interest of time, I'm going to go back to Kate to ask the next question.
So, well, before we go, we've got time. It's very informal. Paddy, do you or Maria, you can unmute if you want. Do either of you have a comment about Raspberry?
So
Maria.
Oh, sorry.
Paddy, you go first. No, Paddy, you go.
Well, because I could ask. So, would you mind if I could answer one question, because it'll actually answer one of the other questions that's come in reverse order, and then so ACE inhibitors and AKIs, there are some data which will come out from the UK from inpatient COVID very shortly, so which will show there's an association with being in an ACE inhibitor and developing AKI. It's an association, it's not causation. Please don't even go there. But I just that will come out. But I think the other thing is, I'd like to just answer Richard Glaze's last question. So I think it's really important is that there was a remarkable decline in dialysis for COVID associated with AKI in the US, and exactly the same thing has happened throughout the UK. Is there was a very early massive surge in dialysis need from March through to about May, June or so, and that's drifted down quite a lot. And those data will come out, well, as soon as somebody signed the bits of paper to make the data appear out, those data will come out fairly shortly in NDT. So I hope that answers the last question. But I'd like to hear if Maria's able to unmute. I saw she turned her camera on for a little bit. So Maria, can you give us your thoughts on the relationship between RAS inhibition and adverse outcomes?
My thought is that we have not to go that fast, and in my opinion, people was taking out these medications really fast, and we become crazy. So I think that until we don't have evidence, we cannot do that with another outbreak of pandemic disease. So, you know, my colleagues were taking out renin-angiotensin system blockade to all of the friends or the fathers. This is no way to work. So I don't think either that they are deleterious or beneficious. I'm not sure about that, but what's important is that if you have chronic kidney disease or if you have heart disease, these drugs are good because are delaying your mortality and your events. So you have to, I think that you have to wait and see where the evidence is going.
Yeah, I think that's
okay. Thanks.
Very, very helpful. Kate, would you like to ask the next question? I think we're lining one up.
Yeah, and sorry, Maria, for putting you on the spot there. Can I come to this is a question that's not in the chat, but so in low and middle income countries, there's probably going to be far fewer measures of GFR. So can you maybe pass comment on that in terms of what you were saying about AKI, CKD, etc., with using GFR measures?
Yeah, so I think again it depends on the availability of registries, and it kind of highlights the importance of why sort of the use of routinely collected electronic healthcare data can be helpful. I think Laurie has done some work in lower and middle income countries in this sort of aspect, so she may be able to highlight what is available and what isn't. But it may be that where routinely collected data isn't as widely available, we use other methods such as sort of prospective cohorts, for instance.
Okay. So I guess it's just a sort of inequity, isn't it? And we've kind of seen that inequity as a theme throughout the whole of COVID. Laurie, what do you think? Do you have anything to add to what Vi said?
Yeah, no, I agree with what Vi said. I think there's an enormous difference in low middle income countries. They're very much not alike. And so if you compare, say, India or Brazil, where actually there's many sources of extremely strong data collection, to most of sub-Saharan Africa, where there is virtually none. And as Vi mentioned, there's lots of very good quality work going on in prospective cohorts in parts of sub-Saharan Africa. For example, fantastic antibody testing and random sample of the population of SARS-CoV-2 SARS-CoV-2 infection, which is extremely informative, but they don't have the linkage to kidney disease outcomes. So from that perspective, it's very limited.
Thank you. And so back to the audience. So Dr. O'Sullivan is asking, does the emergence of new variants since initial papers, vaccination rollout, treatment regimes require the analyses that you've referred to be run again in expectation of more nuanced and relevant risk assessment? So Laurie, perhaps we could come to you with that question first.
Yeah, that's a really good question. In the UK, kind of pandemic waves have aligned with different variants to some extent, and that makes it hard to disentangle the effect of the variant from changes in management and other temporal factors that might also have impacted on outcomes. In current analyses, we are stratifying all of our work by the wave of the pandemic to distinguish, those things over time. But whether we should rerun the original paper is actually a really interesting question, and we haven't done that. And it's a question of whether we could really improve the methodology if we were to do it again and see changes over time. It's a really good thought.
Thank you. So Paddy, do you have an opinion about this? I suspect you do is the answer.
I've always got opinions on everything, but I'm not sure my opinions are fairly that informed. But I think the challenge, and I'm sure most of this audience know this, but Richard Haynes highlighted last week at UK Kidney Week some data from the recovery trial, which showed very clearly that dexamethasone and tocilizumab clearly had some influence on AKI, which is interesting, and the Ronapreve probably didn't. But but that doesn't fit into the whole wider picture of outcomes. But I think, yeah, do we really want to rerun all these analyses again? Probably necessary, but it's exhausting, isn't it? But I think vaccination is another thing. The other thing is variants. I'm no expert, but I think there's conflicting data. I think it's fair to say from the UK, and I think it's one of Scandinavian data on whether the Delta variant causes more severe disease and whether that includes AKI or not. So I think it's just continuing to change. And clinically, of course, we're still seeing some quite bad disease in people with CKD with the Delta variant who've been vaccinated. So I think it's a huge question in itself.
Yeah, absolutely. Have you noticed any difference if you've looked at this in terms of which vaccine people have had and the risk of COVID? Laurie or V?
Sorry, I thought that question was for Paddy. Say it again.
Or Paddy, whoever wants to answer. So I just wondered if you've noticed any.
Well, I can always get an answer.
Any vaccination data, and if you noticed.
No, but I could spin it around to something else. So something else in the UK that's been done very nicely. Because so you probably saw this Lancet paper from Rupert Beale's group showing that it unfortunately looks like the AstraZeneca seems to have less effect in people who are pretty vulnerable, dialysis patients against the Delta variant. But I don't think that's really the same question. But clearly, the types of vaccine, again, it's the timing. There's so many factors because different people got given different vaccinations at different times. Healthcare workers all got Pfizer pretty early on. The elderly got AstraZeneca a month or two later. I think it's much more nuanced than just saying, oh, Pfizer great, AstraZeneca not so good, or Astra for good T cells. I think it's going to be much more nuanced by the type of population and where they got it and why they got it. So thanks. No, sorry.
Can I add to Paddy?
On you go.
Yeah, so I completely agree with what Paddy said.
Yes, of course you can.
Really highlighting the difficulty of observational studies on vaccine effectiveness. And we've done quite a lot of work with Open Safely on this, and really it's extremely challenging for the reasons that Paddy highlights. And in particular, if you think about the clinically extremely vulnerable patients and how the different types of vaccines they got makes disentangling that extremely challenging. And so, as Paddy said, the kind of biological data on biological effectiveness may be actually much more useful here than the observational data, or linked together later.
Yeah, thank you. So Dr. Blasek asked a question way at the beginning, wondering if you could clarify the risk of death from severe COVID-related disease to GFR and how much of this risk can be attributed to older age.
Yeah, absolutely. So in that original forest plot which I showed, that data is all very finely adjusted for age using a 4-knot spline. And so it's kind of the best possible age adjustment. So all of the risks are in addition to the age effects. So in that sense, it's entirely separate from age. But what's really interesting is how much those things are simply a risk factor for dying as opposed to dying from COVID-19. And if you compare the risk of dying from COVID-19 as opposed to the risk of dying from anything else for a whole range of risk factors, including reduction in kidney function, actually you're as like, the difference for your increased risk of dying from COVID-19 is not that great at the same age and level of kidney function. Where the groups that particularly stand out there are patients with organ transplants who did have a much higher risk of dying from COVID-19 because obviously they're pre-selected to be a healthier patient group than patients with advanced CKD without transplants. So yeah, it's very much independent of age, but to a large extent reflects the risk of dying.
Okay, thank you. Jeanette Brookfeld from Sweden wonders how long it'll take for there to be long-term outcome to be followed in the UK with regard to new CKD compared to the US VA study. So Laurie, I don't know if you want to go for that, or V, if you feel that you could answer that one. V? Oh yeah, Laurie's pointing the wrong way to Dia, but on my screen, but I'll not ask Dia. V, on you go.
Yeah, so that's something that we're working on at the moment in collaboration with the national core studies, which Laurie mentioned. So yeah, watch this space.
Okay, you can't give us a teaser.
We haven't done the analysis yet, but it should be, we should get it in the next few months.
Okay, perfect. Paddy, do you want to add anything? You have any comments to make?
I have no comments to make on that. Other than, I guess it goes back to the kind of, sorry, I just asked both the panelists. We had these headlines in the Guardian and on the news, that we're going to need, we're going to need more dialysis machines. I haven't seen that in our own clinical unit. I wonder, is there any insights into, are there more people in dialysis than there were in 2019?
I don't know, actually.
Because that was the kind of story that the news was saying, we're going to need 10,000 more dialysis facilities, or some kind of crazy number that I'm just picking up with the top of my head. But you know what I mean, Fee?
I mean, in East London, we've been really struggling over the past year or so with our dialysis slots, but that may also be related to the impact on transplantation. So, having been able to transplant a lot less people, our dialysis is bursting at the seams at the moment. But yeah, hopefully we'll be able to look at that on a sort of more national level and see what the impact is.
Dia, I have interest in something in the States.
So I think as Dr. Glassgood mentioned, we haven't had as many, I would say, just anecdotally AKIs and dialysis in relation to as we had at the beginning. And then I think to Dr. Brutchfield's comment or question, I think we will eventually have better data for our ESRD patients just because of how the data is collected. Being in a Medicare program that's government funded. So we have data on those as opposed to the other populations. And a lot of the VA studies, there'll probably be more data that comes out of that, but those are also somewhat center dependent too. So it's not the entire VA system that's always used, but they can use the database. But also that's always a more specific patient population than the general, population in the US. So I think that's where we may have some more information from the ESRD side. But that's probably our biggest registry.
Okay, thank you. So there's a question asking about Laurie's the database, the Open Safety database, and the coding, and she's put a link in the chat. And I think she said during our presentation that you could just Google it and you'll be able to find the links to the code, etc. But if you're quick, you can copy the link. So we're 5 o'clock, and we like to finish sharp. Paddy, do you have any final non-rambling comments?
No rambling comments, but I enjoyed it very much. Thank you.
Okay, Laurie, V, thanks very much. That was fantastic. Thank you for taking part on a Sunday afternoon.
Thanks everyone for coming.
Take care. Thank you.
Thank you.
Bye-bye.